caring for children, and I think the same two people who raised their hand again raised their hand. So I was kind of concerned if a lot of the people here are in the wrong conference. So just to alleviate my fear, I just want to know a show of hands, and I hope there are more than 3 hands. How many of you are caring for children in pain? Children in pain? That's good. So we're all in the right room. So we're caring for children in pain, and the first step of that is to assess that pain. So I was privileged to go to a conference in Minneapolis earlier this year called the Pediatric Pain Masterclass, and some of the things I'm going to talk about are stuff we discussed over there. So all the people who are treating children in pain, how many of you are assessing pain on a regular basis? Do you use scales to assess pain? The numerical rating scale, the FACES scale, the FLAC scale? This is familiar to some of you? Okay. So this is some of the things we'll be talking about. We'll be covering the domains of pain, all the different ways that we can assess pain. And under those domains, we'll talk about all the assessment tools you can use. There are quite a lot of tools, and I will not be able to go into detail. That will be beyond the scope of this lecture, but I'm going to present those tools and briefly talk about their applications so that depending on the setting you come from, the sort of patients you see, their developmental level and their disease, you can choose those tools and maybe go back and read them so you can apply them in your setting. And I'll conclude with WHO guidelines on assessing pain in children. So there's a lot to cover, and I'm very scared of that bell at the back, so if I skip some slides, just bear with me. But what I want you to take home is just an idea of the vast complexity of pain assessment, that it goes beyond just scoring pain as a number. And I want to present you with the tools that you can use to create your own bundle so that when you go back to your setting, you know what you can use for your patients. So children express pain in different ways, as you all know, depending on their age and developmental level. So this is from the WHO guidelines that young children would use words like ouch and point to a body part. From the age of 2 to 3, they can start verbally expressing the word pain. At the age of 3 or 4, they can start differentiating levels of pain so that you can start using an intensity scale. By 5 or 6 years, they can start describing their pain in different characteristics. And by the age of 8, they can start having a full intensity score. They can identify, and they can even start explaining why they feel pain. So that's when you can start getting an explanatory model of the patient's pain, or a biopsychosocial model, which we'll get into. So we start with the domains of pain: location, degree of pain, which is what most of us assess, is degree of pain by using various self-report scales. Quality of pain and the impact of the pain. How does it impact a child functionally? How does it impact the child biopsychosocially? So the most validated tool for location of pain is the body map. A child is asked to color in where they feel pain. And this is validated for age more than 7 years. So in the center figure over here, this is a child describing lumbar puncture pain. So coming to the next, the degree of pain. Most of us use self-report pain intensity scales, but besides that, there are also questionnaires and observational scales. For example, the FLAC scale is a behavior observational scale. So we are most familiar probably with the two at the bottom that we use in children. The numeric rating scale is validated for children more than 8. The FACES scale, this is the original FACES scale. Incidentally, the FACES scale was developed, the authors Breary et al. In 1990. They got about 500 children together between the age of 6 and 8 years old, and they asked them to draw out what sort of facial expressions represent different levels of pain for them. And by analyzing those drawings, they came up with the common expressions as for children represented different levels of pain. That's how they came up with this original scale on the top. It was revised 10 years later by Hicks et al. So a couple of the things they did was they removed the smile because it was felt that children with some severe disease may not be smiling even if they don't feel pain. And they removed the tears because it was felt that just because the child is not crying, especially chronic pain, it doesn't have to look like this. It can be a child who's not crying who's also in very severe pain. Recently, in 2013, authors have studied this scale in 3 to 4-year-olds, and they found that 3 to 4-year-olds cannot express 6 different levels or 6 faces for pain. So they came up with the 3 faces scale, which is validated for that age group. So what is wrong with using these pain scores? What is wrong with using these numbers? So Dr. Amita Mahajan had come here earlier and talked about how she had a patient who threw away the prasad that the parents gave, and that made the patient feel very guilty. So children associate pain and distress. There's a lot of overlap. So sometimes when you try to score pain, you might be scoring distress. That is of various other causes, and treating that with morphine will not help your pain score. So what happened in the US was that they used pain as the 5th vital sign, which we do here also. And the problem with that was pain is not like heart rate or blood pressure or respiratory rate. It's not an objective number. It is a subjective experience. For each patient, it's different. And when you try to make it objective, one of the nurses there was saying that she had a patient with a headache, and the nurse asked her to score that headache, and she said 4 out of 10, and can you give me a paracetamol? So the nurse said, well, if it's a 4 out of 10, I can only give you oxycodone. It's an opioid. If you want paracetamol, you have to tell me it's 3 out of 10 pain, because that's how the system works over there. It's all computerized. So this is the problem. This is what led to the opioid epidemic. Of course, we in India are very far from an opioid epidemic. We are on the other end of the spectrum. We are less than 1% of the population receiving opioids. But the idea is we need to move beyond the pain score. We need to get the patient narrative on pain. So as we talked about, this is the IASP definition for pain. It includes sensory as well as emotional experience of pain. And it is important for us to capture that whole experience. So part of that for children will be other distressing symptoms that we need to look into, like depression, sleep disturbance, anxiety, pain catastrophizing, etc. There are also a lot of biases in pain, such as anchor bias. So for example, if one of you at the last weekend you were in vacation in Ladakh, and I asked you today, how is the air quality in Delhi? You might base your answer on your experience of the air quality in Ladakh last weekend. This is what happens with pain as well. We anchor our pain experience to our previous pain experiences. Another common example of anchor biases is children normally go to either extremes of the pain scale. So they tend towards the 0 or towards the 10. That's just how they read or use a pain scale. So we talked about intensity reports. We'll talk briefly about the questionnaires. So as per the, this pediatric pain questionnaire is based on the McGill pain questionnaire for adults. The WHO recommends asking questions like, what words do the child and the family use for pain? What are the verbal cues? What helps the pain? What does not help the pain? And the temporal, and basically a whole bunch of questions beyond just the degree of the pain. So this all works for the kids who are verbal and who are able to answer those questions. What about the ones who are pre-verbal or those who are cognitively impaired? That's when we use behavioral observational tools. So for acute pain, the most common behavioral indicators are facial features, grimace, they're crying, they're moaning, they're groaning, their body posture, things like that. But what you have to realize is in chronic pain, it doesn't look like that. You can have a blank face, you can have a patient who is quiet, withdrawn, not moving. You might think that they're not in pain, but they might be in very severe pain. It can manifest in different ways, and you need to keep that in mind. So the most common behavioral observational tools, I'll only talk about FLAC in some detail, but just to go through the others, PBRS, the procedural scale, this is used in cancer therapy. So for kids undergoing lumbar puncture and bone marrow aspiration, we use it to assess procedural pain in that context. We have a score for neonates, we have one for premature. CHEOPS is for post-operative, in the post-operative setting. Comfort is for the PICU setting, PICU setting. So basically the idea is I encourage you to look up the ones that are relevant for your setting. NICPIC, that is for cognitively impaired patients between the age of 3 and 18, it's validated. I'm just going to focus on the FLAC scale, which I think some of you are familiar with. Basically, it just goes through face, legs, activity, cry, and consolability. 0 means nothing, so face, there's no particular expression, legs, no movement, activity, lying quietly, crying, no crying, etc. 1 is occasional, so there's occasional grimace, occasional kicking of the legs, occasional squirming, occasional whimpers. 2 is continuous, so you've got continuous grimace, continuous kicking, jerking, crying steadily, and difficult to console. So this is how we score out of 10, and this is validated for preverbal children, that is up to the age of 3 years, and any cognitively impaired child up to the age of 18. So it is validated for both these patient populations. So we talked about location and degree. I'll talk briefly about the quality of pain and the impact. So this is a questionnaire that was validated for use in children who have nociceptive pain. So for various mixed and complicated pain syndromes, you have you have nociceptive and neuropathic pain, and the way to address those is different, as Dr. Gayatri will come up later and talk about that. So when you have a patient, a child with neuropathic pain, you use certain descriptors like the burning sensation and electric current, tingling. So this is a questionnaire that has been validated for use with children to elicit this. Impact of pain, the PROMIS scale is used for assessing the impact on the child's life. So it asks questions like, in the past 7 days, how much has the pain affected your ability to sleep, your ability to play, your ability to pay attention in class? So these are all the total picture of pain to get an idea of the patient narrative. These are the tools. So we covered very briefly the domains of pain and all the assessment tools you can use for these various domains. So I'll conclude with the WHO guidelines published in 2012. So the requirements for optimal pain management is regular pain assessment.